Just given a brief introduction of who you are, but we already did that already, so you can move now into your presentation and to your speech. So the floor is yours.
All right. So good morning, everyone in Sint Maarten.
Good morning.
Could you mute the mic on your side? Hi. Good morning, everyone. I'm still getting a real echo, so I'm just going to try to ignore that. But it's a little bit distracting. But thank you very much for inviting me to give this sharing at this very important conference in Sint Maarten. So I know that this is the third day of the conference, and the first 2 days we covered the areas of preventive health and also digital health. So I think on the third day we're supposed to talk about sustainable healthcare finances. So I titled my talk is Singapore Healthcare Sustainable, and we are facing some challenges, and I will share more as I talk about Singapore. But I think that how applicable some of the lessons are, I think that there are some similarities, that we are both an island country, but there are also some differences in terms of the size of the population. So let's see what are the similarities. So for Singapore, this is one of the hospitals that I work at, 𝗔𝗳𝗃𝗧 Hospital. This photo was taken just outside the hospital, where the elderly couple here is going to take the public transport home. So this is now a common sight in our hospitals to say that we have elderly patients who are accompanied by elderly persons coming into the consultation room, and sometimes we have to ask them, okay, so who's the patient and who's the caregiver? Our elderly population is now increasing significantly, and if you look at the ratio, now at 2022, we are at 3.8 of the ratio of 65 years to the 20 to 64. Our population is at 5.6 million, and our total life expectancy is at about 84 years. So I wanted to show you the population pyramid, but I also wanted to kind of put a face to the population that we have here. So on the picture, on the slides, you can see my grandmother, who's 86 years old, which is kind of the average lifespan for an elderly female in Singapore. And then we have my mom, who is 69. So yes, if you do some math, you realize that my grandmother gave birth to my mom at 17 years old. So this was in the post-World War II era, thereabouts. And then, coming down to me, I'm 42, and my kids are 10, 11, and 7. But if you shift left to see the pyramid, we are in a stage of looking at 5 to 10 years down the road, our elderly population will just increase, and we do have a challenge of not enough babies being born in Singapore. Our total fertility rate is about 1.0. Government has been trying a lot to encourage people to have babies, but not so successful. And why is this important for us, and also looking at how can this be sustainable for us financially? Singapore is moving fast into becoming a super aged society. If we look at France and Sweden, what took them 40 and 52 years to do, South Korea and Singapore are going to do it in slightly less than 10 years. So what this means is that we are changing, our society needs are changing fast, and our healthcare needs are also changing very fast. So when we speak about Singapore healthcare, most people would have very good things to say because standards are high, it's good quality, but it comes at a cost, of course. if we look at the health expenditures on the top right-hand side of this slide, we can see that the expenditures have increased at about an average rate of 8% per year, and out of the expenditures, the government expenditures have been at about 11%. So this means that if we continue on this way, it's very likely that healthcare costs will become unsustainable, and something will have to give. And the National Healthcare Group, we looked at the ways that will be challenging us in the next 10 years. One of it is frailty. The other one is chronic diseases. The third one is poor lifestyle habits. And the fourth one, which is further down the road, is maternal and childhood conditions. One of the things we noticed about the healthcare consumption is that there's an 80-20 rule, right, the Pareto principle, where 20% of the people consume about 80% of the resources. So on the bottom right-hand side, we have statistics to show that 20% of patients living in our regions consume about 84% of our healthcare resources. And we have benefited from the demographic dividends in the last 4 decades because we had a lot of young people who were in the productive ages of their life, working very hard and not falling sick. And at that point in time, most of our healthcare was very episodic. But if we look at the healthcare expenditure graphs that we have here, government healthcare expenditure has come up from 3.7 to 11.3% in just about a decade, and we are on track to triple our healthcare costs if we do nothing about it. So this is not sustainable. It's expensive, and it's very wasteful, in fact. So I have to share a little bit about the history of our healthcare system so that later when we go into the questions and answer part, there is some context. So we were a British colony up till when we got independence in 1965. There was a short period where we were joined with Malaysia, but we broke away from Malaysia in 1965. That's when we gained our independence. On the bright side, we think that the British left behind quite a strong system of healthcare infrastructure and also people. So we had certain hospitals that were up and running. We had a strong system of outpatient dispensaries and clinics and blood transfusion services. Post-independence, our first Prime Minister, Mr. Lee Kuan Yew, helped to design the system with a strong focus on public health and focusing on the high-value products, high-value interventions such as immunizations and public sanitation. We also spent a lot of effort to strengthen our healthcare workforce by sending our graduates for overseas manpower training so that they can bring back the best practices from the other countries. This helped us to build our healthcare system up to date. One of the interesting decisions that he made was that based on his experience living in the UK and experiencing the NHS system, was that he felt that services cannot be free. So this was a bit controversial at that time in the 1960s, but he did manage to implement 50 cents co-payment on the government polyclinics on weekdays, and on weekends it was $1. So you could see that there was an inner economist in him, talking about supply and demand. And we also invested in a lot of low-cost, high-value interventions such as primary care and maternal and child health services. So our hospitals and polyclinics moved from being government-owned for a large part of the 3 to 4 decades to becoming corporatized. And what does this mean was that we corporatized our hospitals, moving from government-owned to give more flexibility in terms of hiring and firing, and in terms of growth trajectories. Prior to that, all the healthcare workers, doctors, nurses were all civil servants, and that made it very hard to be flexible with the manpower arrangements and also with the salary scales. In 2000, we then moved the healthcare system into two groups to allow some friendly competition, and then throughout the last 2 decades, it moved from 2 to 6, and then subsequently we are back to 3 clusters. So one of the very important part of our healthcare system that people may have read about is our MediSave, MediShield, and MediFund systems. The MediSave system was implemented as early as the 1980s because of the concern about increasing healthcare costs. So even back in the 1980s, healthcare costs was a concern for the government, and this compulsory medical savings account was funded by contributions from both the employee and the employer. But that was also not enough to address the concerns of catastrophic healthcare costs due to hospitalizations or things like cancers. So a MediShield program was implemented in 1990. It started off as low coverage and voluntary, but now it has moved to becoming compulsory in 2015, and we are currently talking about increasing the depth and breadth of the coverage. And for those who are not working, or those who have not enough income in to build up a sizable MediSave account, we have the MediFund that sort of is a safety net to catch those who are vulnerable and have trouble paying their hospital bills. So the Singapore healthcare system, we also spend quite a significant part of our healthcare budget on health promotion. So we have established the Health Promotion Board in 2001 to promote healthy living in Singapore. Then in 2008, where we saw that the care was getting increasingly complex, we created an agency for integrated care to help us to better integrate the efforts around care provision so that it's not so fragmented. And then in 2015, we established an agency for care effectiveness, kind of like the UK's NICE, to help us to make better healthcare pricing decisions through health technology assessments, and also providing clinical guidance on what is the correct tests and interventions to use. So as the healthcare sector continues to grow in Singapore, we are seeing that what the government is doing is, one, growing the number of healthcare infrastructure and workforce. You can also see that the budget has increased significantly. But what is not so apparent is actually the government is actually investing more in public sector, meaning that there's actually more polyclinics, there's more restructured, there's more public sector hospitals. Previously, the government didn't really try to interfere so much with the community hospitals, but that also has been changing because the demand has greatly outstripped the supply, and the government is not able to rely on the community to build and run their own community hospitals. And even for areas such as long-term care, the government has started putting a small foothold in this area so that they are able to learn and then subsequently set normative standards by saying this is how nursing homes should be run. So Singapore, I mentioned, our lifespan is quite long, but what's quite worrying is that we are also spending a lot of time in ill health. So the tagline that the Ministry of Health has put forth was that we are spending the last 10 years of our life in poor health. That message is very catchy. It hits everyone because nobody wants to spend the last 10 years of their life in poor health. And what is causing that poor health? A lot of it is due to NCDs. So diabetes, high blood pressure, high cholesterol. The Singapore government started a war on diabetes in 2016. And there was a lot of advertisements around sugar intake. And now there's a sort of war on high blood pressure also, because there's a lot of campaigning around keeping your food to be of a low sodium content and watching your diet in this space. So the government does a lot of this public campaigning around these non-communicable diseases. So this was a talk that our current Prime Minister gave in 2013, where he already highlighted the major challenges facing us, facing Singapore in the years to come. Aging population was mentioned, burden of chronic diseases was mentioned, and financing of the future healthcare was mentioned. So how have we been doing in this space since then? We realized that the episodic care model is not sustainable, and further investments into healthcare needs to be calibrated also, because we cannot keep increasing our healthcare budget. So in 2017, when we put forth the healthcare budget, we accompanied it with a strategy called the 3 Beyonds. So what this means was that we wanted to move hospital care, move away from hospital care and towards more community care. We also wanted to shift the focus from healthcare to health, that means putting in more efforts around prevention. And we also, we have been talking a lot about quality, right? Quality of services, but we also want to talk about value, which you will know is sort of value equals quality over cost, or outcomes over cost. So we've added in the cost component into the quality and value conversations, and that is a strategic move to help to keep costs affordable. But it worked, I would say it worked, but it probably required a more drastic shift. So this was discussed at Parliament and within the Cabinet, and Prime Minister Lee then came out to say in 2020 that we need to make hard choices for healthcare to be sustainable. I think the fact that sustainable healthcare was a topic for this conference, but also something that was mentioned by the Prime Minister himself in Singapore, shows the importance of this issue. So our Health Minister, Mr. 𝗖𝗹𝗶𝘃𝗧, took over in 2021, and he started off his term by going to talk to a lot of people in the healthcare sector, the providers, the insurers, the patients and families. And in 2022, he put forth this white paper on 𝗖𝗹𝗶𝘃𝗧, a new campaign that promises to change the healthcare in very fundamental ways, and it was consulted in 2020 and launched in 2023. So the key 5 features of the 𝗖𝗹𝗶𝘃𝗧 campaign was around having family doctors, being centered around family doctors and primary care, where we build a relationship through empanelment and enrollment. And each of the, on the top right-hand corner, each of the patients or residents having a personalized health plan is divided by the patient and the GP together. And on the right-hand side, you see the enrollment. That means residents get to enroll with a clinic of their choice. So previously in Singapore, there is no such concept of being tethered to a fixed doctor or tethered to a fixed GP. So everybody just goes wherever the doctor is convenient or nearest to my workplace, or I happen to eat breakfast at this area and the doctor clinics is there and the queue is short, so I'll just go in. So the residents are in fact very used to this idea of choice. So the fact that we are getting them to enroll with a clinic is something, it seems simple, but it's actually quite a big change for our residents. Then at the bottom, we mentioned that Healthcare SG will have a strategy of engaging and strengthening community partnerships, and also talk about health IT and financing policy as key enablers. But Minister is still beating the drum on this. Every time he has to go to the cabinet and the parliament to ask for budget every year, and every year is going up. So he has to come out to say, guys, we have to be prudent and make sure that our healthcare cost doesn't spiral out of control. Just last week, he actually gave a very good speech at the Singapore Economic Policy Forum, where he reflected on how healthcare was one of the most complex areas that he has worked in. And because from an economic perspective, healthcare is not just about economics, but it's also a public good, and it's a basic human right. So all these things come together to make it very difficult to manage, and he cited that healthcare expenditure was going up, and you can't make things free, or you can't overly subsidize things, because then you kind of drive up demand. So he kind of used hypothetical countries to talk about this, but I think a lot of the points that he brought up was inspired by the Singapore's healthcare journey over the last 60 years. Yeah, so this is a QR code. If you want to find the whole speech, it's really good. So I do hope that you find time to read it. And then he went on to analyze the situation of the supply of healthcare being limited and sticky. Right? It takes 10 years to train a doctor specialist, and it takes 6 years to train senior nurse. But then healthcare demand just goes up and down quite easily, and sometimes it's hard to make sure that the supply and demand matches. I think for Sint Maarten also the healthcare workforce is small, so whenever one doctor retires or leaves for another country, I'm sure that there is a lot of impact. So he also spoke on financing, is that whatever the starting point, most countries end up with a mixed funding model. And he reflected that healthcare improvement, healthcare development is really a journey in which there is it's hard to find an equilibrium, and it's a constant juggling act. So if you are going through some challenges, I just want to assure you that we are also going through similar challenges. So the National Healthcare Group is very progressive in how it thinks about healthcare delivery as a good level service provider. So we are not just about responding to healthcare needs. We have taken a life cost approach where we look at what we call a river of life. So we start off with the part about living well, and then when we fall ill, we develop chronic diseases, we move into the phase called living with illnesses. And then whenever we need to come to hospital, whether it's for a surgery, for a cancer, for a fall, for a fracture, we move into this phase called crisis and complex care. And then as we get a bit older and our physical capacity drops, we need assistance with our activities of daily living. We move into this phase called living with frailty. And then the last one is living well, or end-of-life care. So why we did this was because if you look at the left-hand side, the illness model or episodic care model is no longer tenable. Right? It worked well when the population was young, and people only needed to come and see the doctor, and then they're back. right? But when we are facing an aging population with a lot of chronic diseases, an increased prevalence of mental health conditions and system constraints, that model of the 80s and 90s would not work for us now. And on the right-hand side, in green, you see that we want to focus on the positive healthcare experience. We want to look at healthy populations. We want accessible and affordable healthcare. And the last one is also about happy and engaged staff. So the theory and the hypothesis that we are working on now is that a population health approach will help us to bend the cost curve. Right? And this is in a way kind of like the ideal situation. But if you can see, the cost curve bends, right? But it does not flatten and it does not go down. So what this means is that the healthcare costs will still continue to rise, but it will not rise as fast or as fierce as it would have if we didn't change the care model. So two things to highlight in this is that one is that on the left-hand side, you need an investment to change the system, to change the care model. So there's a little bit of a bump at the left-hand side of the curve, and that is the Ministers of Health way to go to the Ministry of Finance to ask for an investment budget to change the care model. On the right-hand side, it is important to reassure our healthcare providers and also our patients that the government, the health ministry of the day is still investing in healthcare, but we're not cutting budget. That is important to reassure the providers and the patients that the government is not cutting budget, because people get very worried once they see that we're cutting budgets. They'll think salaries, they'll think head counts, they'll think quality of care. So this is important to emphasize. Yeah, so I mean, it all sounds really grand, right? The hypothesis and the population health approach, right? But what are the specifics? So in 2021, Professor 𝗔𝗰𝗰𝗀𝗀𝗧, the CEO of 𝗔𝗳𝗳𝗃 Hospital, put forward this model where we are moving away from episodic care to relationship-based care, moving away from facility-based care to place-based care. That means moving out of the hospital. And we experience fragmented care, nobody likes it, so we want to move it towards joined up and integrated care. And unsustainable care, we want to move it to accountable care, and disease-based care to needs-based care. I'll share a little bit more in more detail. On the top right-hand corner, you see the QR code. This will bring you to the open source journal article that was published by Eugene. That was written by Eugene and published in Frontiers, titled Flipping Healthcare. So what this means is that we look at the 5 principles that is put forth, and we think, how does the National Healthcare Group implement and actualize all this? So I will cover the first 3 in more detail in my next slides, and I'll touch a little bit on accountable and population health. So the relationship-based care rides on the back of the National Healthier SG strategy, where each of our residents needs to enroll with a Healthier SG registered clinic, and the family doctor will serve as the single point of contact to holistically manage your care. So we started off by making this available for the residents 60 years and above, and next year we're going to go down to 40 to 59. So this will give us a little bit of a phased enrollment so that our doctors are not too overwhelmed. So to improve our place-based care, on the right-hand side, what you see is that we have mapped out our geographies, and we have implemented this COCs, which is communities of care, in each of these areas. So the communities of care will be the agents, will be the local healthcare team that is looking after what we think is about 3,000 to 4,000 people in each of the estates. So this will then give them a sense of who are the people that have health conditions that need more care, and which are the vulnerable people and subpopulations in their communities. So when we look at integrated care, we realize that we cannot do everything, so we had to prioritize. So the National Healthcare Group, we prioritize 5 big conditions: metabolic diseases such as diabetes, musculoskeletal health, mental health, respiratory health, and cancers. So what we do is that we think population, but we act local. So when we develop these integrated care programs, we develop them from the National Healthcare Group perspective. But when it comes to implementation, we will actually work very closely with our GP partners and also our community care partners to implement them in a local and zonal fashion. So this whole idea of an accountable care organization is still quite new for us, but starting in July 2023, we have been assigned a population of 1.5 million people living in the Central North region, and we started to map out their local care needs, and that is something quite new for us, but we think that it's important so that we know who are the people that have poorer health and need more help. So following on that, what we have done is to look at not just their health conditions, but also the social determinants of health that we know drive certain health outcomes. So educational level, income level, housing type, geography, these all are known risk factors. And then we will have a population health registry of eventually all our 1.5 million people, so that we are able to look at where the needs are and be proactive about meeting those needs. So I've covered quite a lot, and this is my last slide because it's very hard to remember all that, right? So our Minister of Health is also very astute at knowing that people cannot remember too many things. So in Singapore, we like to just focus down on 3 big things. So he has put forth this idea that, let's just tell the narrative in a way that we're focusing on 3 things: acute care, preventive care, and agent care. And in a way, that's a very succinct summary of our plans moving forward. And I think the beautiful thing is that it actually maps very nicely with what the National Healthcare Group is trying to do along our River of Life concept at the bottom, and also our population health strategy of focusing on relationship-based care, integrated care, and place-based care. So I think with that, I will thank you for your attention on this Wednesday morning, and I'm happy to take any questions. Thank you.